spend some more time with you, but obviously the current circumstances don't allow that, but hopefully soon. So I'd like to just sort of outline what I'm going to talk about today. One of the important things that you'll hear me talk about over and over again is that this is not a solo sport. Doing endoscopy, whether it's in pediatrics or adults, is very much a team endeavor. At least in our institution, we work very closely with our ENT colleagues, and honestly, I don't think could do anywhere near as good a job as we do as a collaborative unit. The anatomy is obviously really important to talk about in all neurosurgery, but particularly in the developing skull base. The skull base in a 3-year-old is different than a 10-year-old or an adult. And so understanding the continuum is something that we've spent a lot of time exploring. Being really focused on what the goals of the surgery are is also incredibly important in pediatrics. It's not always the same. For the same exact pathology in pediatrics and adults, we might have very different goals in terms of biopsying or cyst decompression of skull-base lesions versus in adults where we may be trying to be more aggressive. And thinking creativity, I'm sorry, my talk is going forward, and being creative about the ways that we can approach some of these really interesting pathologies. And so I'll talk about all of those in the lecture today. I think that endoscopic surgery in children with brain tumors is certainly not a new topic at all. And
Bon, j'y suis.
I'm sorry, the keeps jumping around on me here. The pathologies in pediatrics may not require aggressive removal. As I mentioned before, many of them are treated conservatively or with radiation or with medical treatment. And so germ cell tumors or gliomas, inflammatory disorders like LCH, Langerhans cell histiocytosis, and craniopharyngiomas don't always require dramatic resection. Sometimes they do, but sometimes just getting a diagnosis and treating the CSF problems is enough. Often dealing with the cystic components is just enough to deal with the tumor while they're very young. So draining the cysts, decompressing the ventricular system. These are totally valid approaches very early on in some of these complex lesions. The intraventricular location of so many of these tumors makes them ideal for endoscopy. And whether it's transcortical, transventricular endoscopy, or endoscopic transsphenoidal surgery, a lot of the corridor ideas and visualization and anatomy is the same. And so thinking about approach and pathology and figuring out the right approach for each child is obviously the goal, just like it is for any other surgery. So again, as I mentioned before, I think most people on this call are very familiar with intraventricular endoscopy, and this is a typical view that you might get through an endoscope, a solid, rigid endoscope that is passed through the foramen of Monro into the back of the third ventricle, where a biopsy is obstructing the aqueduct. And this is purely a diagnostic biopsy with no intent to resect the tumor, but rather just get a diagnosis, divert CSF through an ETV if necessary, and then proceed on to therapy for this, which was I believe, a germinoma. So again, this is not anything that is new to you, but thinking about endoscopy through the nose for me is always important to put it in the context of all of the approaches that are available. So endoscopy through the brain is part of the armamentarium, all the tools that a really well-trained pediatric neurosurgeon should have, just as going through the nose should be. So we also use the endoscope to assist open surgeries. And so this is an example of an open endoscopic assisted surgery where we're doing a very small craniotomy. We call it a keyhole craniotomy to approach a middle cranial fossa arachnoid cyst. And this is a case that can be done open with a microscope and traditional bimanual microsurgical resection, and that's very reasonable. It could also be done endoscopically, purely endoscopically through a burr hole. and traveling down to the opticocarotid cistern as we're visualizing here, or it can be done with a combination of the two. And this is just a case where I felt that the size of the cyst and the degree of the fenestrations that I wanted to make would be much more amenable through endoscopic assisted techniques. And so you do a small craniotomy where you can open and close the dura, which you can't do through a regular endoscopic surgery. And then you still have the ability to use bimanual manipulation, which I find so much more appealing than some of the limited instrumentation that you can use through regular transventricular or transcyst endoscopes. And then, of course, I just throw this in here because even though we're going to be talking about craniopharyngioma today, you can't leave out the fact that, basic training in microsurgical anatomy and techniques is still part and parcel of all of neurosurgical training. And sometimes, no matter what minimally invasive tools you have, you still need to approach things in a traditional technique like a craniotomy. And for this widely disseminated craniopharyngioma, it can be everywhere. So this is just an important reminder that whether it's endoscope assisted, or craniotomy, these are all parts of understanding where transphenoidal endoscopic surgery fits in that big picture. It's not the be all and end all, it's just one tool, just like these are all tools. And then sometimes, like this video shows, you need to be able to have the ability to adapt and change. And so this is a case of a third ventricular ependymoma in which I thought very confidently that we'd be able to get a good resection with an endoscope. It seemed to have a very nice CSF border around it, and I thought that it would be amenable to resecting through the ventricle. And so here's your traditional endoscopic view of the foramen of Monroe, and you can see septal vein and thalamostriate vein. We're separating the tumor off of a pedicle just to separate it away from those venous structures there. And sort of doing some dissection bluntly to create some space around the tumor. And then here now doing some basic manipulation, whether it's biopsying, pulling, aspiration. You'll see soon that the goal of getting into the foramen and getting the tissue seemed like a good one, but it started to get a little complicated once we started getting a little bit of bleeding. And again, probably something that this audience is quite familiar with, that the limitations of transventricular endoscopy are always optics and visualization. And so once we started getting a little bit unclear of our borders and our margins, I personally felt uncomfortable. And so we converted, and I'll show you that in a moment here in the video. Just like all endoscopy surgery, it's always going well until it's not going well. And then all of a sudden things can break loose. So very nice, sucking nicely here, pulling away from the ependema. And then you've got this. And so you can sit there for hours and clear blood and allow things to clear and continue on. But our estimation was that we were going to be wasting time and probably leaving tumor behind. And so we went ahead and converted to a craniotomy here. And so just using the same burr hole, we extended that incision a little bit and were able to quite nicely get down there. And maybe in retrospect, it would have been easier to do that from the beginning. But at least we were adaptable enough to recognize that sometimes you have to change from plan A to plan B. And then as it turns out in this case, I had to go back in because there was a tiny bit of like a little speck of residual on the post-op MRI scan. And so here the endoscope was perfect because we could pinpoint exactly where we needed to go and get a gross total resection. So one case, three completely different approaches all achieve the goals at the end of a gross total resection, which is very important for pediatric ependymoma where you can cure the patient. So, wide-ranging examples of all the different types of surgical approaches to the skull base, but then you have to match those up with all the different pathologies, and everything in pediatrics is rare. You're talking about tumors and congenital disorders of the skull base. And so we kind of thought that the best way to categorize it when we were thinking about this was into these four different groups, either benign neoplastic, malignant neoplastic, congenital malformations, or iatrogenic or traumatic defects like CSF leaks, which didn't really fit into any other category. And so in the schematic here, you can see that those pathologies all have their slightly different anatomical locations and therefore will lead to slightly different approaches. And I'll go through those with you now. At the very beginning, the introduction hinted at some of the difficulty of doing surgery on the developing skull base because of the fact that it's developing. It is true that the nares, the nasal passages, all the sinuses are underdeveloped and smaller. And so these ideas of taking into account these criteria when you're thinking about doing surgery through the nose, particularly pneumatization of the sinus or the intercarotid distance, are all very important to think about, including the closure of the defect. And so we started about 15 years ago looking at this literature when we were just starting to do it. This was a sort of a little sampling of patients that had been published on. And so even as early as 2005, 2006, papers were being published on just 4 or 5 patients who had endoscopic transsphenoidal surgery. So it was novel, and people were just basically transmitting what they were doing in adults into the pediatric population. So we thought it was important to start expanding that a little bit more. And so over this ensuing decade, as we did it more, and here this is a paper we published in 2014, we began expanding our repertoire and looking at our numbers and noticing that as we looked for patients in whom we could use this technique, the patients were there, they just hadn't previously been thought of as good candidates for this. And so we almost never do craniotomies any longer for things like craniopharyngioma, whereas even just 10 years ago, that was the goal. And so not only did we look at our patients, we looked at their radioanatomic measurements and tried to correlate as closely as we can how the pathology and those radioanatomic measurements matched up together to basically show how viable these approaches are in the pediatric skull base, even though the sphenoid sinus might not be aerated, even though they may have very narrow distance between the carotid arteries. As long as you're aware of those and take them into account, these are very safe and straightforward surgeries, but not easy, technically challenging, but safe and worth doing. So as I mentioned before, the goals of the surgery are quite important to think about, an adult versus pediatric. We've talked about those already. And so if you look at some of the goals of surgery in our paper, it was very important for us to indicate that the goal may not always be gross total resection. And so if you're asking what's the percentage of patients that got a gross total resection, that may not be the right question to answer. The right question might be, in how many patients did you accomplish the goal which you set out to achieve? And so for many of these tumors, the goal is different than gross total. And so these were the first 52 patients we published. We have about 80 or 90 now that we probably need to look at our series and write them up some more. And here is our sort of basic categorization of transsphenoidal to the sella, transclival to the odontoid. I'm sorry that my talk just keeps skipping here. Transethmoidal to the cribriform plate, or transmaxillary to the pterygoid plate. And so I'll show you a couple of examples of transsphenoidal transcellular, which is the most common approach. This is what most of you are probably familiar with in terms of taking out adenomas of the pituitary gland or the paracellular region. It's become more popular for taking out meningiomas of the skull base as well. And these are extremely reasonable and safe to do in kids. Even when there's a non-pneumatized sphenoid sinus, it's called Kunkel type here, you can drill that bone out very easily with a little diamond drill, and it basically melts away. It's like very soft, buttery bone, and you're left with the sphenoid sinus. You're essentially pneumatizing the sinus over 30 minutes instead of over 5 or 6 years, and then you're left with a normal sphenoid sinus that you can then approach. And so here's a classic transcellular approach. Let me give this example here of a case that I did with my adult partner, Ted Schwartz, who is the one who trained me in endoscopic skull-based surgery, and Vijay Anand, who is our ENT. We also do these with Ash Kacker, who traveled to Dakar with us last year. And so we always have a pair of an ENT and a neurosurgeon doing these together. So there's the approach to the sphenoid. You can see the ostia right there. And this is our ENT surgeon taking down the nasal septal flap, which is absolutely crucial. And anyone who's interested in doing these cases should really come and think about doing a skull-based course, doing skull-based dissections and really learning this anatomy, because it's not something that you want to figure out as you're doing it. We spend a lot of time in the skull-based lab perfecting the approach, learning how to do these nasal septal flaps and get the exposure that we need. Because as challenging as the approach is and as time consuming as it may be, it makes everything else so much easier when you've got enough room to manipulate with two instruments. And for those of you that have done skull-based surgery, you know the ability to have a suction in one hand and an instrument in the other hand makes all the difference. Again, so here's a familiar view of the face of the sella, right? There's the dura. We use a Doppler always to look for the carotid artery to make sure we have a nice signal. And for craniopharyngioma, you're almost always basically popping right into the tumor. So the optic chiasm is right on top of you. And while it seems scary, you're basically right in the middle of a huge tumor. So we spend a lot of time just doing internal decompression. There's nothing fancy here. We're just basically taking large biopsies, separating away the arachnoid from the tumor. There's usually a very nice CSF plane around the lateral margins of it. There are often some big vasculature in the field. So the PCAs are almost always present, and sometimes in very large ones, you can see the top of the basilar, but they're never stuck to these vascular structures in our experience, and they just need to be slowly manipulated, slowly dissected away. And then once you're in the middle of the tumor, you can be a little bit more aggressive with your suction and some of these decompressive tools. But again, remember, this is a view that you would never have if you were doing a craniotomy for this type of a tumor. That's the hypothalamus, on the side right here. No retraction, right? You're not using any retractors to lift up the brain. You're not splitting the sylvian fissure. You're not retracting any blood vessels. You're looking directly along the axis of the tumor, which is really the goal. There's the back of the aqueduct there at the back of the third ventricle. And so as you slowly dissect and manipulate, you're just basically slowly milking and slowly pulling the tumor down. No retraction on the brain whatsoever. You're looking directly up the axis of the tumor here. And then you basically can see normal tissue. So there's the back of the third ventricle, no bleeding, and this mass pulls out, right? Very dramatic. That's obviously 2 hours of, gentle manipulation. It looks a lot easier in 2 minutes, but that's a clean resection there. And then we reconstruct the floor with a piece of alloderm and a Medpor plate. It's quite easy. Put the pericranial flap, the nasal septal flap on top of it, glue it in place, and we're done. We do place lumbar drains for these patients, and we leave them in for 72 hours. And you'll get a little pneumocephalus as expected, but again, no brain retraction and quite nice. Obviously, the risks of DI and visual disruptance are all things that we think about as well, but you're underneath the optic chiasm and the optic nerves the entire time. You can see them the entire operation, and there's no manipulation of them. So the visual apparatus is completely free and clear. The risks of the pituitary axis, of course, are the same as you would have when you're taking the stalk or an intrinsic tumor of the stalk via any technique. I wanted to show a second craniopharyngioma as well, a little bit more complex cystic one. This was a very similar approach. I think it's worth probably spending a couple of minutes just to look through this here. Heterogeneous, very large, up into the third ventricle, causing obstruction of the foramen. Again, we've sped up the exposure here because this is not the purpose of this, but a lot of time in getting an adequate exposure is incredibly important. And if you don't do that, it will be a lot of suffering because you won't be able to see around the sides. In this tumor, we got a little bit higher because you can see that little reflection in the dura there requires that we get all the way up to the optic nerve. And so this is, basically at the exact same level, but exposure higher will be necessary. So we wanted a little bit more dura exposed. Again, right into the middle of the tumor, pulling down from the optic chiasm, making sure that you got a nice plane there. It's free from the chiasm, so you're not pulling on it. You've got it in your view the entire case. And here a big cyst pops open, gives you a nice decompression. You can see that motor oil fluid that's so classic for craniopharyngioma comes out. This guy is cystic and calcified and multiloculated and will not pull out in a single piece and requires patience and manipulation. But I think you'll agree that there's nothing terribly elegant about this operation, but it's being done through a very small opening. Again, no brain retraction is being done. You have the chiasm on top of you there, perfect visualization along the axis of the tumor. Using the same instruments essentially that you're using for pituitary tumors, angled curettes. We call it a hockey stick. It's that little round, hockey stick. These cysts keep pulling out. Little pituitary rongeurs, dissection, pull, manipulate. And then here's the last piece of that guy coming out. And then the beautiful part is you can put your endoscope right in the hole and look around. You can see up to the foramen. You can see the catheter from the EVD. Completely clean resection. The walls are pristine with no retraction. So, when I saw this being done in the adult population, as a trainee, I just thought to myself, look, this has got to be something that we offer to children. There's no reason why children should be getting craniotomies and kids should be getting craniotomies when adults are now getting this endoscopically. And so, taking the time to think about it and team up with people who are experts was important. So, I think the fact that I collaborated with someone who had done 100 craniopharyngiomas in the adult population first made this feasible. Whereas if you just dive into this by yourself, you're gonna find that it's a little bit too daunting to take on. So that's craniopharyngioma, which is obviously a wonderful indication. I'm going to run through some other indications for when we use endoscopy. This is something that we do for the skull base, where something called, invagination of the dens, basilar invagination. These are congenital abnormalities of the skull base. We see things like this in adults as well. And kids are often associated with cervical spine issues from severe Chiari malformations or traumas. And so you can go straight through the clivus, basically underneath the clivus, straight through the tip of the dens. And I'll show you how straightforward this is to get these decompressions. And so when you've got the dens, let me go back and just show you this picture here. When you've got the dens angulated and compressing the front of the brainstem, I'm sorry that I'm getting all jumpy here. This is a really nice option here. So now we're underneath the clivus. So through the nose, much less dissection. You don't have to open up the sphenoid sinus. We're basically sliding underneath along the roof of the palate here to the back of the pharyngeal cavity. And so the nasal pharyngeal soft tissue is just divided vertically. We take a bovie and we basically create a straight line in the fascia. It goes straight back to the top of the dens, and there are no neurovascular structures in the way. You don't need to do this through the mouth, as was done for 20 or 30 years and was classically trained. You could basically use all your normal instrumentation here. We're basically using kerosene punches to dissect off the top of the arch of C1 and the top of the dens of C2, where it's invaginating into the ventral brainstem. Certainly bimanual manipulation here is extremely important, and it's much better visualization than you would have normally, but same tools, diamond drill bit, curettes, kerosenes, just like doing spine surgery. Plenty of room in the nose to do this, and we've done this in kids as young as 4 or 5 years of age. The area underneath the clivus there is particularly recalcitrant sometimes to dissecting the bone off here, but this is the entire closure. So there's no dura opened, so there's no risk of CSF leak. So you simply use a little needle pusher, take a suture, and you reapproximate the nasal pharyngeal fascia together, tie a stitch, and that completely heals in a matter of a few days. And out of 30 or 40 of these, we've had one of those not heal well, where we've had to go back in and fix the closure. But literally 1 or sometimes 2 stitches is all you require. So quite a nice approach for basilar invagination. This is kind of an example of what this might look like in really severe cases for those of you that haven't seen a ton of these. Ventral compression of the brainstem on the front, Chiari malformation in the back. And so this type of operation requires not just a Chiari decompression, although the tonsils do go down 2 centimeters here. That would do nothing for the severe brainstem compression, dysphagia, and myelopathy. He required a fusion and then an odontoidectomy here to result in this right here, which is clear CSF space in front of the brainstem, resolution of all the deformation of the brainstem. Here's another girl, I think an 8 or 9-year-old girl with same type of pathology, showing really nothing to do in the posterior fossa, nothing you could do in the back would create any extra space, but doing a ventral decompression really created nice space and alleviated her significant symptom, which was the sleep apnea, oxygenation in the 60s and 70s when she was sleeping. And so, yes, she needed a cervical fusion, but that's it. Here's the setup that we use. We're fortunate to have a CT scan in the operating room that we can use to scan during the case, and so we can use navigation. It's not necessary at all. The anatomy is pretty straightforward, but it is a nice luxury to have to be able to navigate and know exactly where you are. We scan at the end of the case to make sure that we've got no residual compression of the tip of the odontoid. Some of the pearls is that the left side is often the more difficult side to resect and is usually the area that we find that we've left residual dens, mainly because for right-handed surgeons, your suction is in your left hand and it's easier to reflect the tissue on the right. And so you've got to reflect the tissue on the left and drill underneath your hands. It gets a little bit less visualized on the left side. And so taking care to remove that bone on the left is really important to remember. It sounds like a very aggressive surgery sometimes, but the patients leave the hospital in a couple of days. There's very little recovery. They are extubated right away and they feed on post-op day 1. So very different than the transoral where they're often left intubated and have difficulties feeding for several days after surgery. So that's changed our practice considerably using the endoscope instead of a transoral technique for that pathology. These are the 7 children that we've done, or the first 7, we've done 10 now. With the odontoidectomies, and they all have very similar pathologies with a very hyperacutely angulated clivus to C2 ratio. That's called the clivo-axial angle here. And that's supposed to be about 140 or 150 degrees. And so when it's very acute, sometimes down like 100 degrees, the tip of the dens is going to be pushing right on the ventral brainstem. And so these kids have dysphagia, sleep apnea, and severe myelopathy typically. And that's from our paper describing this technique. This is kind of a rare indication. It's more of an ENT procedure, but because we do these surgeries as a team, we've seen quite a number of these. They're JNAs, juvenile nasopharyngeal angiofibroma. I'm not sure if this is common in Africa or not. That's a malignant tumor of the sinuses, essentially. But it's clear that this is a case that needs to be done with an endoscopic approach. Sometimes we'll embolize, we'll always embolize, sometimes successfully, the day before with interventional radiology to try and reduce the blood flow because they can be extremely vascular. And sometimes you need to stage them, usually amenable to gross total resections though. Quite a nice approach for a bloody tumor. I'll show you a little clip of this. Again, a little bit difficult to appreciate the anatomy here because it's essentially filling the nasal cavities. And so having an ENT surgeon with us in these cases is often saved us many times from getting lost in terms of the orientation and knowing where we are within the cavities because the normal configuration and ostia between the sinuses is completely lost in these cases, which are often very long-standing expansile masses, which considerable destruction of the normal architecture. So it looks like normal surgery for the most part. You're able to dissect, you're able to retract, you're able to cut. There's limited instrumentation with respect to bipolar. There are new bipolar forceps, which have made some of these more difficult technical aspects a little bit more facile. So the endoscopic bipolars, endoscopic scissors, endoscopic bovi are all part of our set now. But it takes a little bit of time to get used to the pistol grip for some of these instrumentation when you're used to doing open bimanual microneurosurgery. So some other things, some creative approaches that we've used here. This is a case that was really begging for an endoscopic approach because the only option other than that was a large craniotomy with lateral resection of the orbit. This is a residual recurrent rhabdomyosarcoma. So a child who had been cured of disease everywhere else in her body, a little girl, but was left with active disease in the lateral aspect of the orbit. And instead of doing a craniotomy and going through, we approached through the maxillary sinus. I have a nice little video clip of this as well. So when you see the video, you'll appreciate that the lamina papricia is the medial aspect of the orbit, and that's the lateral aspect of the maxillary sinus, right? So the sinuses and the orbit, things that we don't necessarily think about a ton of as neurosurgeons, are intimately opposed. And so if you can get into the maxillary sinus, getting into the orbit is actually incidentally easy as long as you have a good ENT to get you access. And then resecting the tumor completely endoscopically becomes nothing more than normal bimanual, microneurosurgery, but instead of doing it through a craniotomy, we're doing it through a nice little endoscope. Quite a good deal of dissection here because of the prior radiation. And so again, just a shout out to having a really good ENT. There's the lateral wall of the maxillary sinus. The lamina papricia is paper thin. You can literally pop it off with a curette. That's the instrument lifting up the lamina papricia. And now we're incising into the fascia and looking underneath the optic nerve, and there's the mass right in front of us. So I would say that this is, as good visualization, if not better, than you would get through any of the open techniques. And so same ideas, taking the tumor, dissecting it bimanually, finding planes around the outside of it, and taking it out as an en bloc resection. And she's, out of the hospital the next day as compared to, a pretty morbid operation with some disfiguration of her face and eye from other craniofacial approaches. This is her prior to leaving the hospital, right? No evidence of a scar, not bad. Just packing in the nose for 24 hours. That comes out and then they go home the next day. So quite a big difference from craniotomies. And again, not every operation can be done this way, but if you think creatively and think, is this something that I can reach with an endoscope, then you'll start pushing yourself and start realizing there are indications that make this quite amenable. Here's another tumor for which we almost never would need to do this. This is a germ cell tumor, which really should be exquisitely sensitive to chemo and radiation. It should be highly curable, but for whatever reason was not. And this patient was left with a very large mass, was already pan-hypopituitary. You can see the stalk right there, basically right here. This is, not a tumor which has altered the architecture of the chiasm, but has grown right behind it here. And so to get into this very large third ventricular mass, we go right through the stalk. Again, we wouldn't do this in a patient who wasn't already pan-hypopituitary. They were already on complete hormone replacement from their radiation and chemotherapy and the tumor itself. And this is basically a large ball sitting in the third ventricle, making sure it's not stuck to anything. And the idea or conception of doing this through the nose, maybe 5 or 6 years ago, would have been kind of hard to imagine. It would have been like a discussion of all the classic approaches to the third ventricle, transchoroidal, transforaminal, interhemispheric approaches. And here, it's basically an ENT procedure, and then the tumor comes out as a ball underneath the optic chiasm. We may never do another tumor like this in our lives, but certainly thinking creatively that this is something that we can do with an endoscope is, what makes this, a nice technology. It's that these are probably rare indications, but saving this child, a very large morbid operation is entirely worth the extra time that it takes to get there. So we'll skip over the closure since we've seen that multiple times. Here's a case that I hope never to see again. This is a young boy who had an ependymoma of the posterior fossa. So a malignant tumor, probably not curable. He'd already had multiple resections from the back, had radiation and had wound breakdowns, and there was no way to approach this from the back any longer. And when you see this tumor on the video, you'll see quite clearly why it came into our mind that, well, maybe we can do this through an endoscopic approach. The tumor was sitting right in front of the brainstem and right behind the sinus here. So again, if I go back here and just pause it, right? So here's enlarged sphenoid sinus, pituitary up here. So we're not interested in anything up here. We basically had a thin rim of bone and a complete access to this corridor here. So oncologically, maybe we weren't going to cure him, but we certainly had no other options. He had no chemotherapy or radiation options left. And so as a palliative approach, we thought, let's offer him this surgery to decompress his brainstem and perhaps give him some time, which was the goal of the surgery. Again, thinking about what we're trying to do versus what we can do. Here's the very straightforward approach. So we're basically looking at that thin wall of bone, maybe a few minutes of drilling using a straight curette and a kerosene, and we're looking at the dura of the ventral brainstem. So again, not something that you would ever necessarily think of as, an approach that you'll see a lot in your career. But you'll be surprised when you start looking at these different things with the lens of, I can do this from above, I can do it from the side, I can do it through the ventricle, I can do it through the nose. You start recognizing that there's maybe more potential to do these tumors in creative, minimally invasive fashions. And so this is the entire approach, was that little rim of bone, opening up the dura here. The vascular plexus around the ventral brainstem is a little oozy, but you're basically staring at tumor there. Obviously, using the Doppler to figure out where the vertebral arteries and the basilar artery are coming together. But we're essentially just going right through, opening up into the tumor, and then decompressing from the inside. And once you get into the tumor, this is no different than taking out a glioma or any other tumor of a cortical approach. It's decompression, finding margins, getting hemostasis, and closing. So again, this is not remarkable dexterity or anything difficult in terms of resecting the tumor. It's just simple aspiration, dissection, and we're able to resect a vast majority of this tumor. We were able to see normal brainstem on the back end there. We had some difficulty reaching down to the very bottom of it here, but got a very aggressive decompression utilizing neuromonitoring to ensure that he was staying safe during the case. A little bit of aspiration suction here with a device called the NICO, which is an aspirator that fits through the endoscope. Coming in with the endoscope to look around and look at the cavity. Just use some flow seal and gel foam to get hemostasis in the cavity. And then you can see a post-operative scan shows quite a nice resection at the end here. We have the video. Let's see. Sorry. Just wanted to show you the resection at the end there, if I can just pause it at the right time. It's not letting me, but about a 90% resection. So quite a nice opportunity here. So here, I just wanted to present at the end maybe a couple more examples of creativity and adaptation as ways of utilizing this technique to think creatively about pediatric populations. So acromegaly is not something that you're going to see a ton of. This is a patient who had failed endoscopy in the past, failed craniotomy in the past. We're using it now more for recurrent craniopharyngioma, so patients that have had craniotomies first and now are looking for options for recurrent tumor or residual tumor. And so here you can see some evidence of residual scarring. So someone came in here and did a biopsy and wasn't able to resect the tumor. And so you can see the evidence of the prior opening. It takes a little bit of navigation to figure out where you are, and then you're back to opening up the dura. Same idea. You're looking at the face of the sella here. The green is fluorescein, which we use via lumbar puncture to illuminate the CSF at the beginning of all of these cases. It's an arachnoid plane. You can see where the biopsy was done with very little tissue taken, and then the entire mass is still sitting right there. can elevate the chiasm very nicely and dissect the plane between the tumor and the optic chiasm. There's often a little constant vessel there that feeds the underside of the chiasm. You have to make sure that that's not a superior hypophyseal, but it's safe to coagulate and cut that, and that frees the tumor up from the underside of the chiasm. And at that point, that's the only place that it's stuck to, and there you go, and you're now in the third ventricle. That's the solid component. Then there's a soft component behind it that look at sort of milking it away from the walls, allowing the suction just to aspirate that tumor up. Again, similar techniques, bimanual. You'll feel that once you've got your hands in there, you get used to looking up at the screen and using your hands in a three-dimensional space. It doesn't create as much awkwardness as you might imagine, but there is definitely a learning curve to this. And so this is a girl with acromegaly who was cured. And that's just a wonderful feeling to be able to take a child like that and know that she doesn't require medication for the rest of her life. So she's cured and off medication and now disease-free for 5 or 6 years. So this is a very complicated field in the sense that it's technically rigorous. The number of cases is quite small. But if you're in a large center, if you're in a huge city like Dakar or some of the other cities that I see represented on the call today, you're going to have enough patients that if you begin building this program slowly and work with your adult partners who may be more familiar with doing endonasal surgeries, you'll find that there's a lot of opportunity here. Think about the skull base as a continuous asymmetric development, and you have to think about the development with respect to the pathology that you're operating on. You have to be really diligent in looking at the radioanatomical measurements. Think about your planning, think about your trajectories and the angles and what you can get to. If it's not possible, it's not necessary, but image guidance is often a nice thing to have to guide your trajectory, especially when you're learning, so you don't get lost, so you know where the carotid arteries are. These are really important things in the development of a young surgeon's skills and confidence in doing these approaches. And part of why it's really important to think about doing a course in skull-base anatomy and skull-base approaches. We have them in New York. There are great courses in Europe as well. And I highly recommend, if anyone's interested in them, just contact me and we're happy to have you come to New York at some point when travel is allowed again, and invite you to do one of our endoscopic skull-based courses. It's quite safe in children. The outcomes are very good, but build a multidisciplinary team. Find an ENT who's interested in building a program with you. Find an adult surgeon and work together and see the patients together. And you'll find that the patient populations will start to grow as you start to think creatively about how to do these surgeries. I'm honored to say we just published a textbook literally a couple of weeks ago. It just came out after many years of trying to put it together with my partners here, Dr. Singh at Stanford and Dr. Anand Schwartz here at Cornell with me. He was our fellow 3 or 4 years ago. This is something that's going to be available both online and in print. And if anyone's interested, again, let me know. Here's some contacts for our skull-based course. This is several years old, obviously, but the link is the same. And I'd be delighted to go over any of the topics which I may have gone over too quickly or to answer any questions. And once again, thank you very much for the invitation. It's been my pleasure and my honor to speak with you today. So thank you very much.